And the next lecture is going to be given by Dr. Rebecca Burgell, who's an associate professor and gastroenterologist who leads the Functional Bowel Disorders Clinic at the Alfred Hospital and is the Functional Gastroenterology Disorders Service Head from Monash University. She's going to be talking about phenotypic variation in constipation.
Thank you very much for the invitation to speak today. And I've really been tasked with looking at the clinical side of phenotyping in constipation and its role really in how we manage our patients. I'm an academic and clinical gastroenterologist from Melbourne in Australia, where we have a large functional GI disorders service. So I thought I'd start with a case presentation, because that's where we all start when we're seeing our patients. And this one's a 37-year-old woman. Really, she's had symptoms since her 20s. She is distressed by feeling bloating and feeling full. There's some discomfort. She has quite variable stool frequency and consistency, quite a lot of straining and poor emptying, and just feels generally awful and unwell. And I think this is pretty much a standard patient that so many of us have seen. And she feels terrible. She doesn't go to the toilet. She's tried everything, nothing works. And the one that always gives you a bit of a heart sink, you're the third doctor that she's seen, no one knows what to do. And this is a little bit surprising, because actually we have a lot of treatment options in managing bowel dysfunction, ranging from the simple laxatives, the prokinetics, prosecretory agents, rectal therapies, all the way up to behavioural therapies and indeed surgery. Some of them are easily accessible, some of them are more difficult to access depending on where you or the patient may be living. But a big part of the problem is that it's not just horses for courses, and it really is trying to find the treatment that is going to be best for that patient. And that's really where phenotyping comes into play. So a question I get asked a lot is, do patients with constipation need further investigation? And I think the answer to that really is yes, but it is a little bit more complex. It is really important because it does allow targeted and hopefully more effective treatment. And we'll get onto some of the controversy around that later, but I know that has been discussed by some of my colleagues earlier today as well. We know that symptoms are actually a very poor predictor of underlying pathophysiology, and it does seem to make sense that the pathophysiology is going to predict the treatment, and if we have a better understanding of the pathophysiology, we can better target our treatment and our outcomes. This, of course, is going to mean that we're going to change how we approach the patient. Rather than a scattergun approach, we are able to upfront say, this is the likelihood of you responding to this therapy, this is the likelihood of you having a good outcome or a bad outcome, and then being able to really make things happen a lot quicker for the patients, rather than go through the multiple different things that they've tried through their 3 previous gastroenterologists or surgeons. I think, however, that one of the most critical reasons for actually investigating further in constipation is because it improves the patient's understanding of their condition. And that really is critical, mostly because it validates their symptoms. It also really encourages engagement with therapy, and particularly when you're looking at a behavioural or a pelvic floor physiotherapy type of treatment, which involves attending multiple sessions over time. Having the patient invested in what's going on and understanding the pathophysiology is important. It also improves the understanding for the rationale for treatments. And again, when you're looking often at invasive therapies, repeated intimate examinations, that's really important. And ultimately, knowledge is power. So when I look at constipation and contributors, the simple mnemonic that I have in my head is the 3 C's, and that's the contents, the container, and the controller. Now, when we're looking about phenotyping and particularly pathophysiology, we really are looking at investigations that pertain to the container. We're really asking the question, is this a problem with the colon? Is this a problem with the conduit, so rectal or evacuatory dysfunction, pelvic floor dysfunction? Could this be a motor problem? Could this be a sensory problem? Or is it both? Or is this a combination of all of the above? And the reason that's important is because what is happening at the exit of the body is going to affect the rest of the bowel. I know this is a really old study, but I really like it because it's quite useful to illustrate for patients as well. But if you look at doing a manometry study where you place a catheter up into the colon and you place a balloon in the rectum and then you distend that balloon in the rectum, what you see in the manometry and the activity up in the colon is that there is slowing of the colonic activity. And this concept of secondary slow transit is quite important. And that's because it does affect the treatments that we would offer. And again, this is from a while back now from Giuseppe Gironi's group that looked at 109 patients that had predominantly pelvic floor dysfunction. And at that time, everyone was given laxatives, and that's been the mainstay of treatment. And to be honest, unfortunately, it is often used as the first-line therapy up front because of difficulty accessing biofeedback. And they found, though, that really the outcomes were vastly better in those with pelvic floor physiotherapy using biofeedback compared to laxatives, with only just over 20% responding to laxatives. So there is a complete shift on how we would manage these patients based on their pathophysiology. Now, often the question is asked, well, why don't all patients go and have biofeedback? And that is still something that remains a little bit controversial. But again, Gironi's group looked at this and found that it was really only the patients with pelvic floor dysfunction that had the benefits seen with biofeedback. And those with just the slow transit without evidence of pelvic floor dysfunction did not really see the significant improvement over the time course. And again, that's important when you're looking at a therapy that requires a lot of engagement from the patient, a lot of time commitment from the patient, and may be quite invasive as well. So in terms of what we think about with subtypes of constipation, essentially we look at dividing it into normal transit, and that's about somewhere around 40%. Slow transit, less common, around 20%. And then there's an overlapping defecatory disorder, which can occur both by itself in combination with slow transit as well. And that's around about 30%. And there's a big overlap with that of slow transit. Now, whether that is a primary slow transit with a defecatory disorder or whether there may just be a secondary slow transit due to rectal distension, we don't always know. The defecatory disorders we then further break down into the functional and structural as well. And this is important because when we go back to that list of potential therapies that we have in our armoury, it provides us with a bit of a structure about how we might approach it and offering them to patients. And I think that is a nice framework that you can work with your patients and give them a better idea of what is likely to be successful for them. Now, I'd be the first to admit there's a lot of grey areas here, and I would certainly use a bulk laxative in a patient with slow transit. However, I may be a little bit more likely to go towards a stimulant laxative because you may find that you're just going to worsen their bloating in that group, for instance. And I think it just gives you more bang for your buck if you've got a bit of an understanding of what the physiology is in that patient group. The other group where it is, I think, even more critical to phenotype is this overlap with fecal incontinence. And this is actually incredibly common. We've looked at that recently, published in American Journal of Gastroenterology, that looked at about 46% of patients with constipation also had symptoms of fecal incontinence. And if on further investigations, and particularly sphincter function and pelvic floor function, there's significant sphincter dysfunction, laxatives are not your friends. And in actual fact, constipation is almost a protective factor to a degree for the patient, and giving them laxatives may worsen their symptoms. So you really need to have a serious think about the best way of approaching this. The other group where I think is often raised about, is this an important phenotypic difference, is the difference between idiopathic and irritable bowel syndrome with constipation. From my point of view as a clinician, I don't find it such a critical, important difference to make. And really in that group, the physiology, and actually which is the more bothersome symptom for the patient, is probably much more useful than the standard Rome criteria that we use. The exception to that a little bit is pain, particularly in irritable bowel syndrome with constipation. It certainly seems to be more complex and requires more than just treatment of laxation, whereas the pain that we see in idiopathic constipation is more likely to resolve with just laxation alone. So if we're wanting to phenotype our patients and divide them up into more accurate groups of what's going on with the pathophysiology, how do we do this? And firstly, we're clinicians, so we take a history and we look at symptoms. Now, unfortunately, symptoms are actually not very good at phenotyping our patients at all, particularly the Rome symptoms in terms of distinguishing between slow transit, normal transit, and a defecatory disorder. There's been a couple of studies that looked at this more recently that have identified things like urinary symptoms may suggest more a pelvic floor dysfunction or defecatory disorder. Certainly, I see anecdotally, patients that have got pain with sex or using tampons, as well as their urinary symptoms, I see more commonly in those with pelvic floor dysfunction. But overall, it's not great. There is also often quite a mismatch between what we as clinicians and doctors think is an important symptom of constipation and what's important to the patient. And I actually thought this was highlighted quite well by the recent study from Bill Che's groups looking at kiwi fruit, prunes, and psyllium in the treatment of constipation. I was really interested in this study because we use kiwi fruit. Excuse me. We use kiwi fruit a lot in Australia, and many of our patients find it really useful. And when we looked at the outcomes, I was a little bit surprised that actually the kiwi fruit really didn't have such a marked improvement in their weekly spontaneous bowel movements. But then when you actually looked at the degree of satisfaction with the therapy, and particularly the expressed dissatisfaction with therapy, kiwi fruit actually came out reasonably well, despite the fact that it probably had the lowest impact on the spontaneous complete spontaneous bowel motion metric. And I think that's because when you looked into it, many of the other agents actually worsened a lot of the symptoms that our patients think are important, whereas we perhaps gloss over a little bit, which is the bloating, the abdominal discomfort, and the abdominal pain and gas. And that's one of the reasons why, even though on paper, perhaps the kiwi fruit did not look like it was as effective overall, ultimately the most effective therapy is going to be the one that the patient is taking. So I do think when you are phenotyping the patient, really the question is not, is this symptom predicting a particular pathophysiological subtype? But we should be phenotyping them into what are the most bothersome symptoms for that individual. Really, we should be asking what they want us to target. Because often they don't really care if they're not going to the toilet every day or every second day or every third day or even only once a week. What they're bothered about is the abdominal pain, the gas, and the bloating. And if we're looking at using a treatment that's going to worsen that, we're not doing them any favours. You also need to work out what approaches the individual is comfortable taking. We always have a good understanding of what we think is going on, both from a psychosocial point of view and a pathophysiological point of view. But that may not necessarily align with the patient. It may be that they just want a medication approach. They just want a laxative, get it over and done with. Sometimes they might just want reassurance that they don't need a colonoscopy, that they don't have bowel cancer, that this is manageable. Sometimes we may think this patient really needs pelvic floor physiotherapy. There may be a history of trauma. That may not be something that is at all palatable to the patient. Or they may just not be in a space where they're ready to address some of the potential psychological contributors. So I use the Rome multidimensional clinical profile quite a lot here, but I also add into that really what the patient's goals are and the patient's preferred therapies are as well. Because really when I am phenotyping out the patient, what I think is going on from their physiological and their psychosocial, well, that's really important for the formulation. You want to make sure that your treatment that you're offering the individual in the end is the targeted and is appropriate for them, or again, it's just not going to work. The other thing that is important when you're phenotyping this patient group is what comorbidities there are. And really, this is because they are an opportunity for treatment. We can look at depression, anxiety, eating disorders, and we can target our therapies for those. Trauma history, obviously, is very common in this patient group. And there's also important to exclude secondary causes of constipation or medication related. If we did want to then go on to the physiological phenotyping, what can we do? So we can look at a rectal examination. And this is an incredibly useful test and really up to about 80% sensitive at detecting pelvic floor dysfunction. So I think it is something that is really easy to do at the bedside. The problem is it is a little more complicated than a standard digital rectal examination that most people are probably taught in medical school. And therefore, unless you've got the golden index finger of Satish Rao, perhaps the sensitivity is likely to be a little bit reduced. And I think that's where some of the objective measures that have been talked about earlier in these sessions are really quite important. So the options we've got there are to go on for further investigations. And there are lots of different ways of looking at this. Not all patients do require testing, but I think in those that are not responding to lifestyle modification or medical therapy, those with significant symptoms of obstructed defecation, and if it's not clear if they have dyssynergic defecation on a clinical examination. So if they've obviously got pelvic floor dysfunction on rectal examination, I'm very comfortable sending them off for therapy. The other group is in those where I suspect that there may be a structural abnormality that may require surgical correction. So in terms of tests of evacuatory dysfunction, this is controversial. My colleagues have addressed this earlier, so I'm going to go through this very briefly. But obviously, the biggest issue is we don't have a gold standard. So when we look at symptoms examination, manometry, balloon expulsion, and defectography, it really depends what you're comparing it with in terms of how well they perform in ruling in or ruling out defecatory dysfunction. And as a result of that, with the recent London classification, we did have to accept that the findings looking at evacuation on manometry, really we can only at this stage say that it is a minor finding. The balloon, take 1 second to go back there. The other option that we have looking for evacuatory dysfunction is a balloon expulsion test. This is an oldie, but a goodie. It's cheap. There is still ongoing controversy as to the best technique, the best balloon to use, and indeed the best time frame to use to define it. However, it is a good test to rule in whether there is presence of evacuatory dysfunction. The other one that we often use is the anorectal manometry. And I know there's been earlier sessions comparing and contrasting the multiple different methods that we have here, so I won't go into it again. But again, I find anorectal manometry really comes into its own to rule out rectal evacuatory dysfunction. So when I talk through anorectal manometry, I use it a lot. And one of the biggest advantages I have with this is being able to explain to patients what I think is going on. So I am aware of the limitations of the tests, and that is what I do explain to patients. I always sit down with the patient. I show them the images of the anatomy so they understand what we're testing and what the muscles are looking like. And then I go through the investigations with them afterwards. So this is a manometry study. It's essentially normal. This is the squeeze where you can see a good augmentation of the sphincter. And this is normal defecation with good relaxation of the sphincter and good increase in the intrarectal pressures. You can contrast that with a more dysynergic response. And you can see here with bearing down, there's quite considerable contraction of the anal canal as well. This form, dysynergic defecation, looks more at the contraction of the puborectalis, and you can see quite clearly here the indentation of the puborectalis, and this corresponds to this muscle pulling forwards and making the anorectal angle more acute. The other useful thing that manometry can give us a bit of a suggestion about is whether there could be some structural contributors, whether there's a rectal intersusception or an internal prolapse. Excuse me. And as you can see here, there's a descending high pressure band coming down and impinging against the manometry probe there. And in a patient like this, where you can see during the strain, there was good relaxation of the sphincters, but symptoms of obstructed defecation, I would always organise a defecating proctogram in this patient. The last group where I think anorectal manometry is also really critical is when you're assessing sphincter dysfunction here. So in this patient, we're looking at the squeeze, and you can see that most of the squeeze is provided by the action of puborectalis here. And really the sphincter response down here is quite reduced, and overall the sphincters are quite weak. This is a patient that I'd be very worried about using significant laxatives where I'm making the stool much more liquid, as I'm likely to worsen their symptoms. The other important test when we are working out the pathophysiology is what's going on from a sensory side. And this is something that really has been neglected in the literature for a very long time. We know that rectal hypersensitivity is very common. And most recently, we've published that the increasing severity of sensory dysfunction is associated with worsening symptoms as well. And sensory dysfunction is associated with a functional defecation disorder. Rectal hypersensitivity is also important, although that is more seen in the IBS-C group. And it really is important because there's now a number of studies that have shown targeting correction of sensory function, either with medication therapy or with behavioural therapy, is effective and improves symptoms. Other methods for looking at evacuation include the radiological. Again, I won't go into these in too much detail because it has been covered before, but really defeatography and potentially MRI defeatography are the mainstays of this. And there are a number of groups that would also look at dynamic ultrasound. The other potentially important test in phenotyping patients is looking at the colon function and colonic transit. I don't do this routinely because for me, the most important thing is to rule out whether there is defecation dysfunction, because that for me is where the split is between behavioural physiotherapy and biofeedback versus laxatives and stimulant. Where I do tests of colonic transit is in a patient where I may be thinking about a surgical intervention. And truth be told, that's very rare. I think in my practice, I've only really referred 2 patients for consideration of stomas in this setting. But there's a number of different modalities here. There's radiological, scintigraphic, and a number of increasing capsule studies with the advantage that there's no radiation involved in here. And not only do they provide whole gut transit, but also segmental through the stomach, small bowel, and colon as well. So in terms of phenotypic variations in constipation, I think the important thing here, despite all the tests that we have involved here and what we've been discussing for most of the day, most patients actually don't require advanced investigations. The most important phenotyping is actually establishing what's important to the patient and that old adage of patient-centered care. But physiological phenotyping is important as it does help guide therapy, but for me, most importantly, it helps explain to patients the physiology of what's happening and validates their symptoms and improves engagement with therapy. We have a whole host of investigations, and those that are non-responders to standard therapy or where there's really significant symptoms of evacuatory dysfunction, I think that is a patient group that should definitely undergo early further investigations. And really the critical thing for me is to test their evacuation, or if they are potentially looking at surgery, then I would look at their colonic transit as well. However, as we have seen in previous lectures today, there still remains significant gaps. And the big one is there's currently no gold standard test of evacuation. And really the big problem there is the treatment outcome really should be the gold standard that we test the test of function against. Because if we're not improving the patient's quality of life by the test, by improving access to therapy, then it's probably not a good test. There is still very limited evidence supporting the clinical utility of tests of evacuation, even though it is a really critical area. But a big part of that is the heterogeneity of technique and reporting parameters, which I've no doubt has been discussed in depth by my colleagues earlier. So really the critical next step is those clinical studies using the standardised London criteria to take this forwards, because I do think this is going to be so important. We just need to get the right test, the right parameter, and the right modality locked down. Thank you.